You are listening to the Charles Bonnet Syndrome podcast. My name is Shaimond Foy, and I'm here with my co-host Eva Potts. And today we have a special guest. His name is Dr. Leonid Skorin. He's an ophthalmologist with neuro-ophthalmology fellowship training who practices at the Mayo Clinic Health System in Alberta Lee in Austin, Minnesota. He is also an assistant professor of ophthalmology at the Mayo Clinic College of Medicine and Science in Rochester, Minnesota. How you doing, Dr. Skorin?
Fine. Good morning to both of you.
You are our first ophthalmologist that we've had. We've had someone that's a psychologist, but we haven't had a ophthalmologist. So we're grateful to have you here with us.
Great. I'm looking forward to sort of giving you the ophthalmic version of our understanding of Charles Bonnet Syndrome.
That sounds good. So we can start right away, and I'll just ask, what is Charles Bonnet Syndrome?
That's, of course, a great question. And before I can answer that, I'd like to sort of go through some of the ophthalmic issues regarding hallucinations versus illusions. But first, for us in the eye field, we deal with things that are either negative visual phenomena or positive visual phenomena. And negative visual phenomena we see all the time. So that's people coming in to see us who their visual acuity is down because they need a refraction update in their glasses or their contact lenses. Some patients may have developed what's called, this is still all the negative visual phenomena, may have developed what's called a scotoma, which is this area of loss of vision, but it's surrounded by normal vision around it. We see this a lot in patients who have glaucoma or macular degeneration. Their sort of their central vision sometimes is affected. And sometimes they have these larger losses of vision, which are known as visual field defects. And usually we run automated visual field computerized testing on them to basically plot them out so that we can see what they look like, because the visual pathway is complex, but it also directs us to where the problem may be. Is it in the eye? Is it in the front part of the brain? Is it in the back part of the brain? Right side, left side? We can actually do these visual field tests and plot those things out. And we see this in people who have glaucoma, of course, people who've had a stroke and have lost vision, trauma, or even brain tumors. But we're going to be talking about positive visual phenomena today, because that's where Charles Bonnet Syndrome fits into. But before we can start talking about Charles Bonnet Syndrome, we need to basically distinguish between illusions and hallucinations. And both of these are positive visual phenomena that patients can experience. So we'll cover illusions here for a moment. Illusions are actually misperceptions of viewed objects, and that means somebody's looking, let's say, on a rope, and they see it as a snake. Or somebody's looking at a young lady that's wearing a polka dot skirt, and instead of seeing polka dots on it, they see what looks like insects that are moving around or on that polka dot skirt. So those are illusions. And most of those are could be neurologically as an etiology, but they're also caused often by optical abnormalities, and they could be monocular or binocular, meaning one eye or both eyes. But we're going to now concentrate on hallucinations, and hallucinations is a category where sort of Charles Bonnet fits into. And hallucinations are different than illusions because these are actually sensory perceptions. In other words, something that this person is seeing that really is not there. Okay, so it's a subjective experience. The person themselves is experiencing it, but there's no objective stimuli. So unlike that person who sees a rope and thinks it's a snake, here there is no rope for them to see. They see an illusion of some sort. There's no external stimulation to the eye. And the other interesting thing about hallucinations versus illusions is that a person who has hallucinations can actually still see the hallucination even if they close their eye, while of course an illusion, if they close their eye, they would no longer see the rope, or they would no longer see the polka dotted skirt or anything like that. Now, back in the 1990s and early 2000s, um, there was a term bandied about known as pseudo hallucination. If people go back and look at some of the literature from back there, they'll see that term. And people are trying to distinguish hallucinations that patients were perceiving but thought they were real versus hallucinations that people were seeing and thought that, and these patients knew that they were not real. So in other words, they had this preserved cognitive insight. And that's where the Charles Bonnet syndrome fits into this pseudo hallucination, although in reality, we're not really using that term as much. But still it fits into the category of a hallucination, something the person's perceiving without actually seeing anything there, but knowing that that is not real. Now, people with Charles Bonnet who first experience it, sometimes they don't know it's not real. It takes them a little bit of time sort of to figure it out. And then once they realize it's not real, then of course, from that point on, they understand that it's not really there. So both of these disturbances we were talking about, like I said, can affect the neural visual pathway anywhere, starting from the eyes, because the eyes are an extension of the brain, basically, all the way to the back of the brain. But the hallucinations, unlike illusions, which can also be caused by optical abnormalities, basically they're always just involving the nervous system, or their neural events, if you want to call them that. And so that's a bit breakdown between the two. Now, the hallucinations themselves basically are broken down into two forms. They could be unformed, simple or elementary, or formed, complex. And interestingly enough, patients with Charles Bonnet syndrome can have either one of these occurring. So the simple or elementary ones could be dots, spots, sparks, streaks, wavy lines, and these are known as photopsias. Or they may see their environment uniformly tinged in a single color. Those are known as chromatopsias, and it could be any color. In the old days, when people used digoxin, for instance, and had digoxin intoxication, and that was a drug used for congestive heart failure and atrial fibrillation, when I was in medical school back then, people would come in and we knew they were having trouble, they were overdosing on that drug, and not on purpose, and they were developing what's called xanthopsia, or yellow vision. Today, I have patients who experience blue vision, or cyanopsia, a lot of times after I've done their cataract surgery, because blue is one of the first wavelengths that people lose with cataracts. It's called a shorter wavelength. And when I do their cataract surgery, all of a sudden, all that wavelength is streaming back into their eye, and they're perceiving it. And so their system's almost overstimulated, and they see everything blue. But luckily, that only lasts for a few days to a week, and then it fades away. So I always thought that was sort of these chromatopsias. And finally, the last unformed, simple, or elementary hallucination people can see are known as geometric patterns. And this could be lattice-like or branching patterns. It could be fortification spectrum or tychopsia. And that could be experienced by patients with Charles Bonnet syndrome, but that's also a very common hallucination that patients who have migraine headaches also experience. So all of these could be experienced in other etiologies of hallucinations, not just Charles Bonnet. Now, the formed ones are the complex ones, and these can range everything from metamorphopsia, which is like if you're looking at a bunch of light poles or telephone poles, and instead of them being straight, they're all sort of bent or curved or in a row. And that's distortion, basically, that doesn't necessarily also have to be in Charles Bonnet syndrome. It could even be people who have macular degeneration can see that too. People with Charles Bonnet syndrome could have macropsias or micropsias. So there's a change in the size of the image that they're seeing. And as a matter of fact, it was written about, and this was, and if they're seeing smaller people, which is a very common thing that people with Charles Bonnet may experience, as smaller than normal sized objects they're looking at, people or animals, and that's known as Lilliputian, and it's basically after the islanders of Lilliput, which was written about by Jonathan Swift in his Gulliver's Travels. So that's where that word comes from for these little people, animals, or objects that people with Charles Bonnet syndrome may see. They can have what's called telopsia, which is where objects are perceived to be further away or closer than they really normally are. They can have mosaic vision, which is like fractures of an image into little facets. So sometimes they may be looking at a somewhat like a face is in front of them, but that face is distorted where the eyes may be mispositioned or the nose, or they may see a displacement here or there from where it normally should be. They can have macrosomatognosia or microsomatognosia, where they will perceive a part of the body as disproportionately larger or smaller. And they may also have this Alice in Wonderland phenomena where they could have this distortion of the body image that they're looking at. So that's what hallucinations are, and all of these things can be seen by in Charles Bonnet syndrome, either these elementary, simple ones, or these complex hallucinations.
Well, thank you for explaining everything and breaking it down like that. That was very helpful to hear, and that's very enlightening. You have taken a special interest in Charles Bonnet syndrome. Can you talk a little bit about that? Because there's some doctors who are unaware of it, and there's some doctors who are aware of it, but they kind of put it on the back burner and don't really deal with it. So, can you talk about that process of how you became interested in Charles Bonnet and putting an extra focus on the condition?
You know, it was interesting when I knew about this podcast. I sort of thought about this. When was the first time I realized about Charles Bonnet? And I don't know. I'm sorry, I can't remember. I mean, I don't. I'm trying to think back where in my training I may have been taught this. And I actually think that the first time I ever saw a patient with it is actually during my neuro-ophthalmology fellowship that I did. So that was a little bit well beyond my, and yes, I am an ophthalmologist, so that means I went to medical school, then an ophthalmology residency. But before that, I was also an optometrist. And I don't remember either in optometry school or in medical school really anybody formally teaching me about Charles Bonnet syndrome. I think I first time I ever experienced it was clinically. And I was sort of fascinated by it then, and I'm equally fascinated by it now. I think it's because, and we were talking about this a little earlier, Shaimond, but I think it's because we don't have an answer for it yet. And so it's like I was saying earlier, it's sort of like you're reading a mystery novel, and you're enthralled by it, and you want to get to the end to see what the final chapter, everything sort of comes together. We know who did it, things like that, and we're not there yet. And so your interest is still very peaked, and you're looking forward to the end. And so I'm really sort of very thankful that I'm able to be involved in this mystery of Charles Bonnet syndrome. But one thing I'd like to point out is I teach optometry students, osteopathic medical students, nurse practitioner, and physician assistant, emergency department fellows. They rotate through our clinic, and I've been doing it for 20 plus years. And I find that, especially in the optometry students that are coming through today, that they have a better, they already know, I think it's being taught in their schools for the most part, because most of them are coming through and they have a knowledge of it. So that I think that's great. I think medical schools, and some of these others, I'm noticing they are not as well. They're not getting the formal introduction to it. I'm sure they'll see it clinically somewhere, but there's no formal introduction in their training. At least I haven't. It seems like they may be a little deficient in that.
Okay. With Charles Bonnet syndrome, there are certain things that can help it. Like if you improve your eyesight, maybe have cataract surgery if you have that, and then a Charles Bonnet can go away. And there's certain other conditions that can be treated. But some of these chronic conditions are pretty much untreatable. I mean, so this is kind of like question is a little bit out there, but I'm going to ask it anyway. Do you think in our lifetimes we will ever get to the point where there will be able to be an eye transplant that provides vision to someone that has like a severe eye disease? Because that could potentially help eliminate Charles Bonnet syndrome.
Yeah, if it's an eye-related disorder, which is yes, which is basically that's what we're talking about. The answer is right now there is no way to do an eye transplant, and I don't know if it's something that's available in the foreseeable near future. So that's the best I can answer that. I do want to point out, what you said is there's some chronic conditions out there of vision loss that people wind up experiencing, especially we see this in the elderly, like the one I suppose I think you were alluding to is macular degeneration. I see a lot of patients with macular degeneration, unlike cataracts, where almost any cataract, even the ones that are very thick and hard and a person can barely make out whether a light is on or off, you can successfully still remove that cataract. And assuming the back of the eye is healthy, that person can, recover an immense amount of their vision back relatively after a straightforward surgical procedure, a cataract surgery. But macular degeneration is a different animal. Uh, I it, it wasn't until about 2005, I believe, when we started having this ability to inject medication for patients with wet macular degeneration into their eye. And I'll tell you, it sort of was like a godsend. I mean, patients went from, I used to tell them, well, unfortunately, you have this thing called wet macular degeneration. We really don't have anything to do for you. We can laser your eye, but you'll probably lose your vision. Maybe you'll lose less vision if we don't laser it, but you're going to lose your central vision. And now we have what are these intravitreal anti-VEGF, which is vascular endothelial growth factor injections that we can do in the eye for people who have wet macular degeneration or exudative macular degeneration. And I've seen people where they come in, they have bleeding in the back of their eye. They have swelling in the back of their eye from this wet macular degeneration. We give them a series of injections each month apart, 2, 3, 4 injections, and they go from 2400 or 2200 vision almost back to 2020. It's to me, eh, this treatment modality is a miracle, basically, for people to recover their vision. Now, it doesn't happen to everybody. Not everybody responds that well, but the majority respond, and a lot of those that respond very well. Um, we only had one medication at that time. We quickly got a second, a third. Now we have half a dozen or so different medications that some are stronger, some are weak, some do different, they work in a slightly different components, so we can match and, mix and match them. I have patients that one of the drugs works better for their right eye, but the other works better for their left eye, or vice versa. So we don't even have to give the same drug necessarily to each eye if they have wet macular degeneration in both eyes, for instance. And it's just amazing, how we can reverse in many cases, or at least stop or slow down the process so they can continue to function, go back to reading, driving, living independently. It's a really a big change in how we approach this. And um, I don't know how many people out there know, but within the last year, there has been FDA approval for two different intravitreal anti-VEGF injection products out there, medications for a particular form of dry macular degeneration, those patients who have geographic atrophy. And I assume that with additional approvals, maybe through the drug companies and additional products in the pipeline, that may be expanded to other forms of dry macular degeneration also. So up to now, we haven't been able to do anything for those people. And by the way, dry macular degeneration is the bulk of the population that have macular degeneration. It's about 10% who get wet. They start off dry and then convert to wet, but the majority stay dry all the way through, and they continue to lose their vision also, albeit in a slower time frame. Of course, it takes longer with dry to lose that vision, but they still wind up losing vision. And now we actually have these new medications and potentially other new ones that will be able to intervene. So I think your question is, could we do an eye transplant? It's not here yet, but we do have these other things that to me is very exciting, because we're able to, with my cataract surgery, with these injections, I'm able to give people back the gift of sight. I mean, that's a precious gift, I think, for all of us. And if you do that, as you had pointed out in your introduction to this section, you had mentioned that there are surgical procedures like cataract surgery. Those work great. I've done cataract surgery on patients who have had Charles Bonnet syndrome. They have had improvements in their vision, and it does resolve that problem. So whatever you can do to improve a person's visual acuity beyond that particular threshold for that one patient, you can um, eliminate, I guess, Charles Bonnet syndrome, but you have to give them that visual improvement. So the only other thing I'd like to mention, and this is not any research that I'm doing, but the audience may be interested in this. I read this in a, a, a journal called Review of Ophthalmology, the December 2023 volume 30, number 12. I believe it's online if you wanted to go, if you're out there and you wanted to go and look it up. It's about neurostimulation for vision restoration. So I made a few little notes, so I'm going to read some of this. So it's one of the potential vision therapies is this repetitive transorbital alternating current stimulation. All right. So it basically delivers an electrical impulse to the retina, the optic nerve, and the anterior brain. And basically, what they're trying to do is they're trying to modulate any damaged brain networks. So they're working with brain plasticity. So before we used to think the brain has no plasticity at all, but now we know that it does have it to some extent. And they're working in this capacity in people who have glaucoma, like severe glaucoma. And glaucoma is actually a form of optic neuropathy. So there are other diseases out there that can also cause optic neuropathy. So I wonder if it's not something that beyond glaucoma, they might also start looking at those diseases. And of course, if your optic nerve is damaged, then the image, the signal is not transmitted further down to the brain. And so you can't see your vision, you can't see. And so people who have end stage glaucoma, for instance, can certainly also develop Charles Bonnet syndrome. So what they're doing here is um, they're taking cells, these nerve cells, these ganglion cells, um, that the cells around the ones that are dead from glaucoma. It's called a penumbra. And those are not dead. They're just weakened or not functioning as well as they should. They're known as silent neurons. And what they're doing is they're reactivating these silent neurons to improve the vision by this electrical stimulation. And it's sort of this electrical stimulation that they're utilizing mimics the brain's electrical impulses, helping the brain's functional networks, that plasticity, that brain plasticity we're talking about, sort of to reorganize it themselves into a more normal structure. So basically, you're taking the cells around where that are still um, alive but not optimally functioning, and stimulating them to take over the job for the ones that are no longer functioning, are dead from the underlying disease. In this case, they're talking about glaucoma. So I'm just going to read you here a very short one paragraph, the conclusion of these scientists. What does neurostimulation research add to our understanding of glaucoma pathogenesis? I think it helps us understand that not all neurons that aren't functioning properly are dead. There may be some small fraction of the damaged neurons that we're able to recover. The scientist, emphasizes um, that this form of neuroenhancement shouldn't be confused with neuroregeneration. So, in other words, they're not bringing back the dead cells. That was what you had mentioned earlier, eye transplant, because those would be dead cells you're talking about. They're stimulating the ones that are not functioning optimally and getting them to function better. So that's the distinction. So they aren't actually bringing any neurons back to life. So that I wanted people to understand that too. But if they're interested, they could look this article up. I think they should be able to understand that it goes further deeper into the specific research, how they did it, and things like that. But this is all cutting edge stuff that probably, I would assume, if it works, you'll be able to take this home and do it yourself, because they're looking at possibly coming up with a product that people could just go home and use this therapy to re-stimulate their cells, their retinal cells, that's another thing that's very exciting, something we would have never even considered 20 years ago.
So hopefully I wrote this down correctly. The repetitive transorbital alternating current stimulation that you were talking about, is that the same thing as transcranial magnetic stimulation?
I don't believe so, because isn't that magnetic waves? This is electrical currents.
Okay. All right. So they
So,
are two
so this
different
is where
things.
it's using
Uh-huh.
alternating current stimulation. So it's
Okay.
electrical impulses that they're doing. So I think the idea of getting things stimulated to work again is the same. So we're talking about, but this is a different avenue to get there.
Okay, because some experts actually said that transcranial magnetic stimulation can help with Charles Bonnet syndrome, And there's been certain people that have been speaking about that a lot. But I remember I was in a couple different support groups, and people that had Charles Bonnet syndrome got that, and they said it didn't help. And one lady said that you have to get it over a series of months or weeks. So she said while she was getting the treatment, she said it helped her, and the hallucinations went away. But she said on her last treatment, she got it, and then she went outside, and she was living in Florida at the time, and it doesn't snow in Florida. And she said as soon as she went outside, it started snowing. And then she said immediately after that, the hallucinations just came back. So that was a little discouraging to hear. And one thing that's a little bit challenging or can be challenging about this condition is what works for one person doesn't work for someone else, and what works for someone at a certain time doesn't continue working for them. It's so many. I don't know if it's because the brain is so complex, or is the personalities of people are so complex, but it definitely keeps me on my toes as someone that's a supporter and an advocate, and someone that's trying to help. And I'm sure you, as a doctor and other medical professionals, I don't know if you have any thoughts about any of those things I just
Well,
discussed.
well, yeah, actually, I do, and thank you for bringing that up. I, so, the magnetic, that's so the way addressing, um, you're addressing the problem in a different fashion. So here you're addressing the problem by going to the root cause. This where they're using the alternating current stimulation with those electrical impulses, because you're trying to stimulate the the ganglion cells adjacent to those that are damaged. And so you're trying to get them to work better so that they hopefully can transmit the image better back to the brain. Does that make sense? And so you're addressing it in a different. So I'm working on the front part of the engine. You're working sort of on the back part of the engine. We're trying to get the engine to work in the car so the car can go, but we're addressing it differently from two different locations. That's why I think maybe this neurostimulation actually um, uh, uh, again, it's rudimentary beginnings, but they're looking at this to actually get people to see better because of their glaucoma damage from their glaucoma. But someone who also has Charles Bonnet syndrome because of glaucoma damage, if you could stimulate those retinal uh, uh, nerves, again, specifically the ganglion cells that they're talking about, um, that will help them see better, and that secondarily will help eliminate the Charles Bonnet syndrome, hopefully. Does that make sense?
Yeah, yes, it actually makes sense. I wanted to go back a little bit to something that you mentioned earlier, and thank you for being transparent. And correct me if I heard you incorrectly, but you said you received very little to no training about Charles Bonnet syndrome when you were studying to be a doctor, and you found it in the field while you were talking to your patients, because you're a good doctor and you were listening to your patients and you were figuring some things out and doing research. So if that is the case, and you also said that you are a professor and you teach doctors. So I have a few questions. The first question is
I teach future doctors.
teach future doctors. Yeah. So the first question is, do you discuss Charles Bonnet? You may have said this, but I'm not sure. But do you discuss Charles Bonnet with some of your doctors, future doctors that you're training?
Oh, absolutely. As my practice is So first of all, anybody can get Charles Bonnet if they have an serious ophthalmic issue that diminishes their ability to see well. Okay, so you could be any age to get it, but statistically, the majority of people who get it are in their 70s to 80s, and the reason is that the older population is unfortunately also the population that gets more eye diseases such as macular degeneration, glaucoma, cataracts, things like that. So it sort of it makes sense that Charles Bonnet syndrome um, incidence is basically skewed towards the elderly population, but it doesn't have to be all elderly population. But my population that I see where I practice is skewed to the elderly population. Just because I live in an area that's sort of a retirement community, it's a more rural. There's a lot of there's just more older people, so I see them, and I do cataract surgery. So many patients who need cataract surgery may also have glaucoma and may also have macular degeneration. So I see all those patients also, and so I see currently in my last 24 years of practice here in Minnesota, I have been inundated with Charles Bonnet syndromes. If you could say the word inundated, meaning I see quite a few of them compared to a lot of doctors who, especially if they have a younger population, may never see a patient with Charles Bonnet syndrome, or if they have a general population of, half younger, half older, they may occasionally run into one or two or three in their career. Um, uh, but So the students that rotate with me, we see many Charles Bonnet patients, and like I said, the optometry students are currently, they come in, most of them already have a working knowledge of it. It's just the others, because well, it's just such a specialty issue. They don't, in their training, they have so much general training that there's a lot of these specialty issues, like even they may only spend 2 weeks rotating at an eye clinic during their whole medical career training. I mean, so in those 2 weeks, if there's a Charles Bonnet syndrome patient, of course, we'll talk about it and they'll know about it. But they're there to learn how to use the slit lamp, the ophthalmoscope, how to take out a foreign body from the eye, how to look in the back of the eye with an ophthalmoscope, things like that. So that's where their emphasis is when they're in our clinic. They're in assisting me in surgery, things like that. But I did have an optometry intern. This was back in 2004 or six, I remember. Who's on his first day on his rotation, and he was going to be with me for 3 months. On his first day on a rotation, we had a patient who came in with a newly diagnosed Charles Bonnet syndrome. And he just happened to be the one who took this patient back to work him up. And he comes to me all befuddled. He doesn't know what this is and stuff like that. To me, I mean, I sort of got an idea right away, but it was a big a learning experience for him. He said he never heard of it in school. Anyway, so he was so fascinated by that one patient that I said, "Look, you're with me for 3 months. I'm sure we'll probably find a few other Charles Bonnet patients in the 3 months because I have a large patient population that I see." And I said, "Why don't you um, uh, keep a record of all of them? We'll make sure you see every single one of them, and let's write up an article at the end about our experience over a 3 month time frame of Charles Bonnet in a busy ophthalmology office." And basically, we found, I think, 6 or 7 cases with the student during that 3 months frame in my practice. Now, a couple of those were, I think, patients that I sort of knew they were coming in for follow up, and I knew they had Charles Bonnet from before. But to the student, these 6 or 7 people were all brand new. All of them had their own specific story, and we wrote about Charles Bonnet, and we sort of published those cases all together. And so the student got a publication out of it and learned something important about an entity that when he came in, he knew nothing about, but when he left, he was an expert in it. So, but unfortunately, like I think I mentioned, and I had one of those emergency fellows. I think she was a physician assistant, and she was with me only 2 weeks, but within that 2 weeks, we had a patient come in with Charles Bonnet. She had never heard of it. We discussed it, and she wrote it up and had it published in one of their physician assistant journals. And the other student, the optometry student, we published this actually in an ophthalmology journal. So one of the things I'm trying to do is if I do have a student and they show first of all, I teach them about this problem, but if they show a further interest in it, then I try to get them to put something together so that and then write something up or give a presentation at some meeting or something like that, so as to sort of let the medical community out there uh, know about it if they don't know about it, or remind them about it if they do know about it but maybe are not seeing it on a more routine basis. And this way they will always be in the back of their mind so that they will recognize these patients, and if they can't help them, at least send them on to someone who can help them.
That's where I'd like to ask you a question, Dr. Skorin. We're finding in our support groups the frustration among our members is that they go to their ophthalmologist, even their neuro ophthalmologist, and what they're told is, yes, you have Charles Bonnet syndrome, but there's nothing you can do about it. And the resources in the United States, as you've seen and we've all witnessed as either caregivers or people with Charles Bonnet syndrome, is that we're limited on resources, support groups, etc., where to go get help. And this is kind of a convoluted and long question. I'm sure several questions can come out of it. The frustration about A, being diagnosed properly, B, then being diagnosed, and then you're kind of on your own because there are no solid answers. It would be nice if an ophthalmologist would say to the patient, can't help you, but here's some information on a support group. And of course, that's coming in the United States. But what do you think it would take? What will it take for medical schools to finally recognize this? Because if ophthalmologists and future doctors such as yourself are being trained properly and they've heard of Charles Bonnet syndrome, when it's presented to them, they don't really offer much advice to their patients about what's next. How can I further help you? They pretty much ignore them or send them on their way. And what would be your advice to the medical community? What would you say to the medical community to wake them up a little bit? Because and I'm glad you said it out loud, this affects people of all ages. Yes, the targeted population of the elderly is predictable because everybody's vision is going to decline as they get older. Not everybody, but most people. And I know I've really asked a lot of questions and in a short amount of time, but I think you can see where I'm going with this. What's it going to take for the medical community to wake up and treat this properly?
Wow. I don't know if I have a good answer for you. I think it's a multiple step answer. Um, One of the reasons I think it's not um, as readily, I think in ophthalmology and optometry, I think for the most part, I think we got it. I think it's a rare person out there who's never heard it, because I've gone to meetings where I'm lecturing on a different topic, but there is someone else at this meeting lecturing on hallucinations, lecturing or specifically lecturing on Charles Bonnet syndrome. Eye meetings, when I go to eye meetings, okay? And I've personally tried to also give these talks to general like state medical meetings. And I find that neurology meetings are good too, because this is a neuro-related problem, of course, because it's hallucinations could be caused by other neurologic things too. So to introduce that, and psychiatrists also should know about this. But I think family physicians, general medical doctors, are a great place to sort of try to expand this knowledge base, because they see everybody for everything. The biggest problem is that, as you had mentioned several times in your question, is what is there to do to fix this? And unfortunately, there is either no fix, or there's potentially several different fixes that may not fit into that clinician's wheelhouse to do. For instance, if they see their family medicine doctor, that family medicine doctor not only has to identify the problem, but also has to send that patient on to get an eye exam, whether from an optometrist or an ophthalmologist or a neuro-ophthalmologist, to potentially find if there is an underlying ophthalmic etiology that can be potentially corrected, like cataract surgery. I had one of the patients I had came to me for cataract surgery consultation, and she had very advanced cataracts, but was told, well, you also have macular degeneration, so probably there's no rush, there's no need to do your cataract surgery because the potential may be a low yield because you also have macular degeneration. But by taking this lady's cataracts out, true, I did not cure her macular degeneration or that part of the vision loss that she had from macular degeneration, but um, she had enough visual light stimulation and improvement in her peripheral vision to the point that her Charles Bonnet Syndrome literally went away. And that was because although I wasn't able to fix her driving acuity or her reading acuity, the rest of the additional vision improvement was sufficient. So I would say that try to get these people to the other clinicians who are actually familiar with this disease and may potentially can intervene. Even low vision optometrists even could potentially help because they may be able to fit magnifiers or illuminators or something like that to improve the person's visual acuity. I work with low vision optometrists all the time. If I'm at the end of what I can do medically or surgically, I will send them on to see if there's anything else that can be done optically. So you should make sure that you've gone through all those steps to see if there's any potential improvements. But the bottom line is, for these patients, it's, all of us as medical clinicians should be able, the two things that are most important, I think, are reassurance and counseling. And that is the most important thing I think we could give our patients. The problem is a lot of us are very busy and we have lots of patients, and frankly, reassurance we could give. Counseling, we're not very good at as clinicians because that's not what we're really taught that much. But we shouldn't stop there. We should send them on to someone who's like a psychologist, somebody like that who could go through some potential additional cognitive restructuring training or relaxation training or distraction training. There's other things out there that can be done that, for instance, for me as a surgeon, I just don't have the knowledge base, to do that, but to do that kind of counseling, but also, my job is a surgeon. So I'll do that part of it and I'll do the best I can for them. But a lot of these people are more complex and need, it needs to be more of a team effort than just one person being able to take care of this patient.
I
Does that make
agree.
sense?
Yes, sir. Yes. I'm sorry. I didn't mean to interrupt you. I agree. And I think that you made a very important point that the field of psychology, counselors, neuropsychologists, that field as well should be familiar with Charles Bonnet syndrome because that is a team effort that needs to be connected. And I guess that's what's so frustrating is that we see this connectivity that needs to happen, and how are we going to get there? And that's awareness and education, which is something that we're working on as a nonprofit. But can you give us advice on I guess maybe just keep shouting it from the rooftops, that it needs to be paid attention to, because this also, I'm a psychology student. I never heard of this one time when I was in school. And, I've talked to many counselors about this, and the counselor who worked with my mother had never heard of it. So, beyond the regular training of becoming a psychologist, clinical psychologist, or a clinical counselor, you name it, in the field of psychology, they don't know about it, so there's going to be additional training for them as well. And it's there is that point of frustration, but that's a very good point that you make, because without that team effort, how are we going to solve this?
Yeah, so that one lady that I told you about that had macular degeneration, cataract, and I was able to cure, quote unquote, cure her Charles Bonnet syndrome. That's a rarity.
Yeah.
Most patients, you're able to improve. I can do some improvement, hopefully, to their vision. The optometrist might be able to do some additional improvement optically, but they still need. We still need other people on our team, because we don't have a full rostrum. We need a full rostrum. That includes a psychologist, I think, and counselors. I honestly have never had a psychology student or psychologist ever come through my clinic with me, because they're down the hall and up a couple flights. That's a psychology and psychiatry, they're over there. I just assumed, obviously incorrectly, that this might be something that they cover, because they must cover hallucinations in general are a common theme, I would think, in psychology and psychiatry. Psychiatrists will try to, I think, treat everything with drugs, and unfortunately, drugs, although there's a number of different, like, anticonvulsants and neuroleptics that might be able to have been tried, none of them really work good. They might, but usually they don't. And so, unfortunately, pharmacologically, we don't have a good answer for Charles Bonnet syndrome. So, and I don't prescribe any of those drugs anyway. Those drugs fit into psychiatrist's department. So I haven't even looked at their dosing since I was in medical school, basically.
And I
I'm
agree with
curious.
you. I
Oh,
think
sorry.
many people agree with you. That's okay, Shimon, that the psychotropic drugs are not making the impact that doctors would hope that they would with the Charles Bonnet syndrome. And excuse me, I think that the answer lies in making sure that this gets into the educational aspect with psychology majors. And I see this extending into the school system, where we can identify these children with low vision, or who have their vision affected by uh, you know retinal diseases or challenges with vision, otherwise injury. I think there's a plethora of people that are, I wouldn't say so much letting them down, but we also have that stigma attached to it, where people are hallucinating and they won't come forward. So we're just wondering how many people are left out. Hallucinations in psychology, I think normally they're referring to schizophrenia, that type of thing, and that's also a misdiagnosis of Charles Bonnet, as you well know. So I hope that by people listening to you speak, and by paying attention, that we're going to reach somebody that's going to say, okay, yeah, we need to start including this in the curriculum and the education process for other fields that this impacts. It impacts almost every medical field you think of, because somewhere along the line, that person is going to admit to some medical professional what they're going through. And then that person can say, hey, I don't know much about that, but let me get you to somebody who might be able to help you a little bit more.
And that's why I think I mentioned earlier, I'm a big advocate for, like, family physicians, to be aware of this, because they may not necessarily. They're often the front line on some of these patients, because patients will often confess all kinds of things to their family physician, because that's someone that they've known for a long time, they trust, and as long as and they're the conduit for the rest of us, quote unquote, specialists that should get those referrals, and then we could start doing what we can do to improve these people's vision, and hopefully resolve their hallucinatory issues.
One thing that I think that will be helpful, and many other people think this also, is to be able to, when you see an ophthalmologist and the ophthalmologist says that you have a chronic condition where you're losing your eyesight, and you have either lost significant eyesight or you will lose it, to give like a little pamphlet or give a sheet of paper saying that there is a condition called Charles Bonnet that is possible and it affects 30 to 40% of people that lose significant eyesight. What would it take to get something like that done? So, because there's ophthalmologists, most ophthalmologists that I'm aware of don't really say this to their patients. And then when they start experiencing these hallucinations, they get frightened. And then they
Yeah.
got to find
Well,
out going to Google about it.
right. Well, there are no pamphlets, as far as I know, out there. I'll tell you what I do. In my practice, I have copies of that one article I wrote. That more extensive article I wrote up with that optometry student and the cases we saw. And it's sort of thicker, so it impresses the patient more. So I hand it to them and with their family, or somebody else's, hopefully they're with them. And I say, look at this. This is something that's well known. It's written about. And by the way, I wrote about it. That gives them even more credence. And then I explain, and I go and I try to do some reassurance and counseling. I definitely do the reassurance and as much counseling as I have the time for, I'll try to do it with them. As I read about it, let me know if you have any other questions. And then next time I see you, because usually they do have a chronic problem, so I'm going to be seeing them back again, maybe for a pressure check in 3 months or a look in the back of their eye to check their macular degeneration, et cetera, et cetera. So these patients, they come back with additional questions, and I'm able to help them. But that's not everybody out there. So I'll tell you, this has nothing to do with Charles Bonnet, but there's a disease out there called benign essential blepharospasm. I don't know if you've ever heard of it or not, but that is also a neuro-ophthalmic issue that until, a few decades ago, nobody really knew about it and always thought it was something psychiatric, which it is not at all. It's neuro-ophthalmic. But what happened was people got together to have this problem, got put a nonprofit, got a nonprofit out there. They actually started putting out their own literature. That's for you, Eva. This is for you. Putting out their own literature. They started sponsoring research into it. They started getting physicians who and other clinicians who had interest in it to apply to various meetings, neurologic or ophthalmologic or optometric, to go out and basically do presentations and let them know that if they see this problem, their patient could be, this is what you do to fix it or how to help them. And this is material you can get. This is the website of the nonprofit that has a great support group. And it's a big to do now. And it also started off as a sort of unknown or poorly known, poorly understood neuro-ophthalmic disease or issue or syndrome that basically has this giant advocacy for it now. And I think we may be at that threshold with Eva's work to get there too. So what I'm saying is, I don't think you're going to get any medical group necessarily or anybody out there who's going to do that kind of work, because there's probably just not enough patients per specialty, etc., that they have the capacity to put the additional funds and or time and effort into. So it would take something like an advocacy group probably to put something like that together. That's my opinion.
Yeah. And that's where we hope to be going. And from your lips to God's ears, that's where it's heading. And we're working in that direction. It's a much slower process than we would like. And we definitely have the support of many, many people, as such as yourself, which we're so grateful to have you as just A, on this podcast, B, as a supporter of what we're trying to do and advocating for us as well. And being open to speaking about this, because I think part of the problem is that it's seen as an orphan diagnosis, and it certainly is not. If we're working on the same scale that the UK, where they're identifying approximately 1 in 3 individuals with low vision or no light perception are experiencing Charles Bonnet syndrome, then we have a pretty hefty number of individuals in our country that are suffering in silence or afraid to say something or have been screaming from the rooftops but not being heard. And if they're hearing this, they can contact us and we'll hear them.
Right. And I didn't use the term you did, orphan diagnosis. I think that that's exactly it. But like I said, that other BEB uh, was also an orphan. And now they have grown up. And I don't see why. Uh, the criteria, the model is out there. It's something maybe we could sort of just copy and hopefully have an equal success.
Well, I plan on, as I found you, the ambitious phone call. I've got no problem calling them and maybe even coordinating. Thank you for the information, because that's my next endeavor, is to find out who they are and what's going on, what they're doing. Thank you, Dr. Skorin, so much for all your time, your efforts, your talent. Just thank you for what you're doing for Charles Bonnet syndrome and for the people who suffer from it or who are challenged with it. They're not suffering, they're challenged. They're trying to figure it out, and we're trying to help them.
Yeah, they're trying to figure out as we are also. Yes, thank you very much for this invitation. I truly enjoyed it, and I wish everyone well.
I just have one final question. Can you tell us about any books that people can read to get some information about Charles Bonnet syndrome?
Okay, great. Yeah, I'll wrap it up with this. So basically, we were discussing this earlier as what literature could be out there that a lay person, meaning not the clinician necessarily, or a medical person or psychologist, could go to get some additional information. And the one that I think we all sort of decided the best was by Oliver Sacks. That's SACKS, and the book is called Hallucinations. And it's not all about just Charles Bonnet syndrome, but a good section of it is about Charles Bonnet syndrome. And he is a neurologist. He's since passed away, but he has written a number of books, multiple books. And most people probably, if they heard his name before, it's because he wrote the book Awakening, regarding his experiences, and that was made into a movie called Awakenings that won all kinds of awards and things like that. And so he is very readable as a clinician, as a scientist, as a neurologist, where a layperson can read his work and understand it as well as I read it. I read it because I just love his writing. It's very good writing. Another one that I ran across that was recommended to me actually by someone from this support group actually is The Man Who Tasted Words. Uh, a neurologist explores the strange and startling world of our senses. And this was by his first name is Guy, Guy, and last name is Leschiner, Leschziner. And again, not the whole book is about Charles Bonnet syndrome, but there is a good section in it about it, actually about a young lady that has Charles Bonnet syndrome, and then he goes into other details, and I think it's well written also. So either one or both of these, if you're not even if you are a medical doctor, I read them both and I enjoyed them very much. But if you're not, you could read them and understand them very well, and it'll give you some additional information about Charles Bonnet syndrome.